Good morning, everyone. I would like to thank you for joining us this Thursday, October 25th, 2018, for the MDS 3.0 Updates effective October 1, 2018 webinar. My name is Jennifer Summers, and I'm the Assistant Director of Member Services for the Washington Healthcare Association. A few housekeeping rules for today's webinar. Everyone will be placed on mute. However, I do recommend if you've dialed in by phone to press the mute button anyways. If you experience any technical difficulties, let us know by using the chat box, or you may email me at jennifersummers@whca.org. Should you have any questions at any time during the webinar, please type them in the Q&A box, or you are more than welcome to email me. We will answer those questions at the end. The recordings, presentation, and CU information will be emailed to you by 4 p.m. today. With that being said, our speaker is Robin Blyer. Robin is a registered nurse, licensed healthcare risk manager, certified forensic nurse, certified legal nurse consultant, and a certified assisted living administrator. She has worked in healthcare for the past 32 years with a focus in long-term care for 25 years. Robin teaches and presents across the nation and is a well-respected professional with an in-depth knowledge of nursing, clinical operations, and emerging and best practices. Please welcome Robin Blyer.
Thank you, Jennifer, and good morning, everybody. It's a pleasure to be here. As we all know, the changes to the MDS were effective on October 1st of this year, and I know everyone is evaluating their practices and processes and systems. And recently, while we did many programs prior to October 1st, we've actually been asked by many groups to come back and go over the foundation, go over the coding requirements, just to help everyone redesign and reaffirm that their processes are in place. As Jennifer said, if you have any questions, please don't hesitate to send them to her either in the chat box or in an email. What I like to do also is if there's any questions either that we don't get to or after the presentation, I'm a big fan of having them emailed to Jennifer, and then that way we'll do some review and research on them and make sure that we're getting the best answer. There are a few things that are a little hazy to people still, and so what we have been doing is working with the RAI coordinator of each state that we do presentations in to make sure that we're in alignment with that state. Even though this is a federal process, there is some coding directions, guidance that does seem to come from the state MDS OASIS office, and we like to make sure that we are in alignment with your state. So thank you for having us, and we'll get started. So as always, we begin with the objectives, and really what we're hoping that everyone gets from today is to make sure that everyone's comfortable being aware of the revisions. There were items that were removed that we want to make sure are noted. Of course, there were items that got added in the revision, and there were some clarifications that occurred during this change. Now, myself and one of my team members, a gal named Debbie Toomey, went to the Baltimore CMS changes in education on this process, and we went for a 2-day program. So obviously, we have a 2-hour program. So again, either today or later, you may have some questions, and we actually welcome and appreciate emailed questions because that requires us to research, and I think that makes us better. So if at any time, 2 weeks from now, you have a question, I would be more than happy and welcome your question to be sent to us. We have some information. What we've also done is to make sure that we're really focused on communicating the information that CMS has put together, working with MLN, the American Association of Nurse Assessment Coordinators, and all the public domain websites. So this disclosure talks about that, and that this information was accurate as of September 14th. And shortly thereafter, this information was sent to the Washington Healthcare Association. If there's any subsequent changes after that, of course, we'll be able to look at that as well. So obviously you want to make sure you start off by having the right manual. And so everyone needs to make sure that they've downloaded it. So we want to make sure that the centers are doing that. I know that you know that ANAC has those manuals, MedPass has those manuals, your MDS process has those. So it's important that we look at that. we know that the world is changing around us, and in that it's changing around us, we're really all preparing for PDPM, and we'll talk a little bit about that. And so these changes are very specific to helping us to walk in that direction. As a kind of anecdotal comment, I'm sure you remembered that the highest ADL index score attributed to the higher rug rates. Well, now with the changes, that's not going to be so. It's going to be the moderate or the middle ADL index scores that are going to end up attributing to that. So we'll continue to move forward as we go through the information today. So first we looked at Section B, and we looked at the coding tips from Section B. And one of the things that I thought that was very important to really think about is that the interview items are not directly dependent upon one another. So inconsistency in coding among these items should be evaluated. So when we think about the interview, we're really thinking about if the resident completed any of the resident interviews. And that's going to be factored in on how we're going to end up coding BO 700 when we have that look back period for that 7-day ARD period when we're evaluating that. That's going to be really important. Now, some residents don't participate in interviews because they can't. And we know that if they're unable to do that, then we're going to have a 99 on the BIMS or the PHQ-9, for instance, or any of the interviews. However, some residents don't participate in interviews because they don't want to. And that's certainly a resident's right. But you may want to take a moment to think about what is your process in doing interviews. So based on some of these changes and the importance of getting accurate interviews when the resident is able to participate and is willing, I have found some centers have added some new strategies that I'm going to share as we're talking. And in this case, one of the strategies that has been implemented at one of my centers that we've been talking about, they started it in September as we were looking at the changes. And so as we did that, when we were looking at that, one of the things that we came up with was the consistency of who does the interview, not having as many people doing the interview, and the timing of the interview. Now, we know the directions of the interview in terms of when to complete an interview. For instance, the PHQ-9 speaks to the end of the assessment reference date as an example to do that. And so we want to make sure that we get that information at that time. But one of the things that several centers have been doing that I've been closely reviewing with their directors on a weekly basis that seems to be rather effective is actually having one person, doesn't have to be a nurse, that actually has completed all of the MDS interviews. So all 4 areas, to include pain as well. So really when they're looking at the interviews, they're looking for consistency of who's doing them, when they're being done, and then also spending a little bit more time prior to the interview process explaining to the residents that we have interviews and what we hope to obtain from them. So just a piece of information that I hope that's helpful to you in time to come. If anyone tries that strategy, I would really appreciate an email update as to whether or not you thought it was effective or not, because I do have people that are considering it at this time, and I'd love to share your input with your permission. So if we look at the MDS section BO 700, which I have on your screen right now, you'll see, as we're looking at it, the ability to express ideas in one, consider both verbal and nonverbal expressions. One of the mistakes that I've noticed during auditing is nonverbal expression has not been well coded in the MDS. Whether it be someone who can point and consistently, accurately point to something that they want, have it validated by the staff member and shake their head, whether they're able to use a communication board, etc. Those are things that are really needing to be looked at. There has been some information, and at the Baltimore training, there was discussion of the overcoding, rarely and never understood, when in actuality, that related to language, but not the person's ability to communicate and make themselves understood. So that might be something that you might want to evaluate. I think part of that comes also with effective communication between the direct caregiver and the person that's doing the interview. If the resident's not interviewable, that also may have an impact on it. But this was brought up at the Baltimore training. So resident interviews, of course, we talked about uniformity established with the interview process in the MDS, and so that was one of the things that as we reviewed this and several of my clients, we talked about how are we confirming our uniformity, whether it be certain select people, if you're going to have multiple disciplines do the interview, which is your choice and not a problem, or is it going to be people that you've done competency, skill validating? Interviewing residents is a skill, and not everyone has it. Some can learn it, and some really are not comfortable with it. Also, in the MDS manual, in the appendices towards the middle or back of your manual, is where there are interview directions. And the consistency that each interview is conducted in the same fashion following the RAI manual directions is important. And that helps to assure that the information is being matched, and it's apples to apples, if you will. One of the other challenges with the interviews was staff sanitizing answers, feeling that they understood what the resident meant as opposed to what the resident communicated. Determining if the resident is rarely and never understood in writing or using another method is really the area that has a very high focus. If it appears that they're not able to communicate verbally, again, we have to ask, what have we offered the resident to help them communicate in other fashions? It could be writing, and it could be using a language board. It could be sign language if they know how to do that, cue cards. So that's an area that I know that at the training, CMS really focused on the importance that this related to quality of life and the focus that they were hoping that the state agencies would be using as they evaluate our effectiveness in this area. CMS was very adamant about the importance of conducting the interview on all residents, if at all possible. And again, as I've gone into several centers and looked at the residents that have declined or refused an interview, which of course is their right, in having a conversation, I noticed that several of the residents said they did not understand the value of the interview. The other issue that came up in trying to look for the root cause of why might we not be interviewing as many people as we ought to be, it also related to residents' fear. And so again, that focuses back on the normalizing and neutralizing. By the time we see a resident, particularly for their first assessment, that's going to have an interview, they've been through a lot. They've either had an injury or an illness or an accident at home or out of their home in the community typically. They've gone through, they've been in an ambulance. They've gone to an emergency room. Often they've had surgery or acute medical care. They spend an amount of time at the hospital, then they go back in the ambulance and they come to us. And that causes transfer trauma. And I know that we've all seen statistics related to transfer trauma as it relates to emergency preparedness. CMS has really shared quite a bit of information on that, but also as it relates to return to the hospital and why, frequent return to the hospital puts the resident at greater risk because of that transfer trauma, amongst other issues. So when we're looking at that process to normalize and neutralize and making sure the resident understands the value that we expect that they might have some difficulties with some questions and that actually it's normal because of all that they've recently been through. So once we initiate and start the interview, the REI manual tells us that we have to follow those directions exactly for consistency purposes. However, as discussed at the CMS Baltimore training, there's nothing stopping us from assuring that the resident understands why we're doing the interview, what the intent is, which is in the REI manual, item by item, and what we hope to get out of it, and what their return on their investment in participating, as opposed to people becoming annoyed at sock blue bed. So those are something that I hope that you guys can consider in your practices. We know that if the interview was not conducted, and again, preferably this one's supposed to be done the day before the ARD as per the coding directions in the manual, that we're going to code that item as a 1, yes, and the no information coded dash has got to be entered. We are all aware of what the excessive dashes impact on our reimbursement in time to come will be. It says, do not complete the staff assessment for these interviews if the resident interview should have been conducted but was not. And I think that's a clarification that many of us really didn't focus on prior. So this next slide I put up really looks at the actual interviews in section CO100, DO100, FO300, and JO200. So that's pain, daily activity preferences, mood and behavior, and of course the BIMS, for a brief interview for mental status. Should the interview be conducted? So if you say no, then it's telling us to skip. And so that was a clarification that came up over at that training. And it's been my experience from one-on-one trainings where we were in person and or discussion groups that this was misunderstood. Now, I'm obviously not physically with you, and I don't know which your center and your organization did, but this is an area of clarification to thankfully be reviewed. Now we're going to talk a little bit about Section G. Now, the ADL algorithm is really important. And we know that if we code that someone has extensive assistance, we are aware that we're going to code a 3. And as you can see in this text box, it reminds us, did the resident require a combination of total dependence and extensive assistance 3 or more times, but not 3 times at any one level? And so it's going to be having us now code item 3A and 3B, recognizing the rule of 3. So in the ADL algorithm, we're going to convert episodes of total dependence, which was a 4, to extensive assistance when there is a combination of total and extensive. So that is something for us also to clarify and review. Now, the rule of 3 for Section G, and this algorithm came out of Chapter 3, Section G, of course, on page G-8, really looks at the ADL self-performance rule of 3 and going through the process. So if we start at the beginning, we're reviewing these instructions for the rule of 3 before the algorithm, and we want to go in sequence. And that's one of the issues that CMS also brought up, was the failure of some organizations not to go in sequence and stop at the first level that specifically applies for the resident being evaluated. So they want us to start by counting the number of episodes at each ADL self-performance level. Now, of course, there are exceptions to the rule of 3. The rule of 3 does not apply when coding independent, which you can see as a 0, or total dependence, which you see as a 4, or if the activity did not occur, which is an 8, since those levels must be every time the ADL occurred during that look-back period. So the rule of 3 does not apply when the activity occurred only 1 time or 2 times. That's coded then as a 7, since the activity did not happen that 3 or more times. So when we're applying the rule of 3, we are looking at the activity. Did it occur 3 or more times at any one level? Then we're going to code that level. The exception for independent and the exception for total dependence, as noted. When the activity occurs 3 or more times at multiple levels, we're going to code the most dependent level 3 or more times. And again, noting that same exception. When an activity occurs 3 or more times at multiple levels, but not 3 times at any one specific level, then again, we're going to apply the following in sequence as listed, stopping at the first level that does apply. So the third rule only applies if there are not any levels that are 3 or more episodes. So if we have a 3 or more episode occurrence, yet we also have other levels that are identified, we don't look at those other levels that are identified because you've got your minimum of 3, please. So we want to make sure that if there are not any levels that are 3 or more episodes at any one level, do not proceed at 3A, B, or C unless the criteria is actually met. And so the challenge is going to be working with your nursing assistants and your nurses. Now, some states, based on case mix, do not allow the ADLs documented by a nurse to count for their state reimbursement rate. And I am not a reimbursement expert related to Washington Healthcare Association, so I can't confirm that. for your state. I did look online, and I did not see that that existed in your state. It does in others, but I did not find that. If that is so, if someone would email that in, that would be great. But I looked and could not find that. So that would be positive to note, because the states that have that challenge tend to not include the nurses. I think we all know that typically the nursing assistants undercode ADL support, and I think that the extensive assistant sometimes, especially as it relates to a minimum amount of weight bearing, that 0 to 25% typically, seems to be the most problematic. And I don't know if in therapy they use the FEM score or what methodology they use, but of course in RAI talk we have to follow this. ADL training around the clock for your CNAs, having physical examples that are reflective of the care that they would typically give during the shift that they normally work, is the most effective methodology we have found for that most accurate ADL documentation. In addition to that, we have found that teaching the nurses the same. It's a skill set normally of a nurse to document the care that's given, but not necessarily by whom it's given to and or how many. So let's use an example. I was at a center, and a resident was in the dining room, and they had a change in condition. I believe they had a TIA. So they had been assisted out of their wheelchair by the nursing assistant into a standard dining room chair, and I believe that they did so with one person that provided a minimum amount of assistance. A little bit of weight-bearing assistance, not much. Well, when the person had their TIA, obviously it took more. It took 2 or more people, and they provided full body assistance. The person was a total. They didn't participate at all. That wouldn't count. However, after they were back in their bed and they were feeling better, they needed to go to the bathroom. Well, then the resident didn't require total care, but they did require extensive services at the highest level. And they required that by 2 individuals, whereas normally they had extensive at the lowest level and 1 individual caregiver. The nursing notes, when I went back to review this, and since I happened to be there in real time, and I reviewed that, did not reveal the number of staff and the level of assistance that they performed. Their nurse's note talked about the patient was put back to bed, their feet were elevated, oxygen got applied, the standard things that nurses do and talk about. The doctor was called, the family was called, et cetera, et cetera. And those are all good things. But when I talked to the nursing staff afterwards and we reviewed that, I said, well, how many staff did it take? Well, they knew that it took 2 people to provide the maximum amount of extensive assistance to help the resident into the bathroom. And later on, they did document that the resident was able to go to the bathroom with assistance of staff, but they didn't say how many. So you want to make sure that your nurses are helping to contribute to your ADL documentation as well, as they oversee the direct care that's provided by the nursing assistants that are assigned to the patients on that wing. So we really want to make sure that that information is done. And so obviously, we really want to look at the coding and make sure that both the nursing assistants and the nurses understand what we're doing. Now, many centers are not asking nursing assistants anymore to try to use the numbers associated with the MDS, but they've gone more to language. And one of the centers that I was at recently actually did something I thought was really ingenious. Their documentation that the CNA completes, I have a hiccup, was I bear weight, I don't bear weight. I bear weight and I had help of 1 team member. I bear weight and I had help of 2 team members, or I bear weight and I did it alone. And they actually have moved their language to things of that nature that increase their accuracy of the documentation related to the ADLs. Now, if this is something that's of interest to you, feel free to email me about it and I can give you a little bit more information. I really was impressed, though, with the way that the center had done that. In fact, it had gone to their QAPI that as they were doing additional training related to MDS changes, that they identified that the nursing assistants really were having a hard time with accuracy, and they also identified that their nurses were not participating in documentation related to care. Even if it was on a monthly summary or a weekly summary, they referred to staff and that the staff provided the care. But it was not discernible, and the MDS coordinators were having a frustrating time. So those are things for you to consider. Now let's go take a look at Section GG, because we know that there's been quite a bit of changes in Section GG. So completion requirements of Section GG, the original Medicare A residents only. That's that admission assessment period, our first 3 days of the Medicare Part A stay. And we're looking at day 1, question A2400B, and we're really looking at the goals related to discharge and, of course, the admission performance. And obviously what's completed on the PPS day 5 that we document over in A0331OB, which of course is going to be 01. So now when we look at the discharge assessment period, we want to be sure that it's completed during the last 3 calendar days of the Medicare Part A stay. I found that centers are having a bit of a hard time with that, depending on when those last 3 days fall, if they're, how well the communication between nursing and therapy exists, and also if some centers have more set staff on the weekend and different staff during the week, if they run Monday through Friday schedules, and then they run special weekend programs, which I realize we all have workforce issues, and we have to do what we have to do to get the job done and give the best of care. But those are things that as you're thinking about your program, you should consider to make sure that you're comfortable that the team is properly trained and that they have done a return demonstration for you of that understanding. In many centers, they're reevaluating how they're gathering that information for Section GG. And if you need any suggestions on that, again, just send us an email and we'll be glad to send you a couple complimentary suggestions that we've helped other centers put together. It's interesting. And if you have a real special way that you're doing it, if you wouldn't mind sharing it, particularly with Jennifer as well, I'd love to see it. But with Jennifer, if you don't mind sharing it so that others can see it as well. Because I know that we all know that the more we work together, the better our industry and our profession does. And that's important. The discharge performance, which we know is going to be documented in the column 3, is completed only on that Part A discharge assessment and at no other time. One of the mistakes we were seeing was the erroneous times that was being documented in some of the centers that we've audited already since October 1st. But we've looked at that with them and gone over the coding directions, and that has been helpful. One of the things also, and I think some of the more experienced MDS coordinators have told me that they've really kind of taken a step back, is going back to the updated REI manual and really rereading the intent of a section. Why does this section exist? That is really, what does CMS want to gain from this? That has really been an area also that helps in the training so that people understand why we're doing it. Sometimes the staff get caught up with, oh, you're just doing that for money. The MDS is used to gather information that's going to be appropriate for billing. That's very true. But it's also used, as we know, for many other things, quality measures, and to be honest, in consistent care and documentation so that we have better outcomes. Now, when we look at Section GG, when we look at 100, we're looking at that patient's prior functioning everyday activities. And obviously that's going to be important in evaluating the residents, both by therapy and nursing, to see where we expect them to go, looking where they were previously, and then evaluating their current circumstances and what restrictions that might cause. What is the goal of the resident or their responsible party so that ultimately we can make a pathway to help them achieve that as best as possible. So when we look at GO 100, the prior functioning, at the everyday activities, the responder has to indicate their resident's usual ability with everyday activities prior to the current illness, or if there's been a worsening, or if they've had an injury, maybe they've had a motor vehicle accident or something of that nature. So the coding on the left-hand side, we reminded, if it's a 9, it's not applicable. If it's an 8, it's unknown. And it might be that the person comes in and they're cognitively impaired, or they have some acute confusion, and maybe delirium related to anesthesia, et cetera, and we don't have a person who's a reliable reporter to assist us, and medical records don't depict that information. So it's not a deficit if you can't answer it. If it's unknown, it's unknown. I've had some people think that unknown makes them look unknowledgeable to the surveyors, and as long as you've done your diligence, unknown is a perfectly fine answer if it is the answer. If we code a 1, obviously that means that the helper completed the activities for the resident So that's a 1. And the key for this is that they completed the activities. Sometimes that really needs to be differentiated with the staff and understanding when we're talking to them. So if they live at home with a caregiver, what did the helper do versus what they didn't do? If they need some help, the resident needed partial assistance from another person to complete the activities. That might be their spouse. It might be a volunteer. It might be a caregiver. You know, even when someone lived in the community, and ALF is considered the community by CMS, so it doesn't matter who that helper is, just that they received it or they didn't. And then, of course, we know that a number 3 means the person is independent, but that means they did it 100% by herself or himself. And that meant that they weren't helped by somebody else, but they could have had, with or without, an assistive device, with no assistance, again, from someone who provides helping. So based on the coding on the left, now we're going to look and evaluate A, B, C, and D. So if we look at self-care, coding the resident's needs and assistance with their bathing, with their dressing, how they use the bathroom, how they eat prior to their illness, any worsening, any injury, etc. So how functional were they before? CMS wants to make sure that we're paid for the work that we do, but that we're not looking at things that are not in a reasonable prior functioning period. And I'm sure you've heard therapists talk about that prior functioning period. So 5 years ago, the resident was able to do X, Y, Z, but they were gradually declining, and they settled to a place where they were for the last year up until the car accident that they were involved in. So we're not going 5 years back. We're going to that prior level of function where they were consistently functioning. If we look at things such as indoor mobility or ambulation, we're going to code the resident's need for assistance with their ability to go, say, from room to room, whether or not they use adaptive equipment. And that adaptive equipment could include a cane or a crutch or a walker, etc. Now, to the prior current illness or injury period. And so we know indoor mobility for seniors is a lot different when they live in a small environment or their private home as opposed to in your nursing home. So we're really looking at what assistive devices that they need to help them get around, if you will. Now we look at stairs. Obviously, if somebody had stairs in their home and they were able to traverse the stairs, we want to code the resident's need for assistance with the internal or the external stairs that they might have, regardless of whether they used an assistive device or not, prior to their situation, their illness, etc. And then last is the functional decline, looking at their cognition at that time, coding what the residents need for assistance with planning what a lot of people call the IADL, the independent living of daily living, such as regular tasks going to the store, how they remembered or not to take their medication, etc. So the ability for someone to return to their prior level of function, particularly when they weren't in a skilled nursing facility, is going to include that IADL aspect. And we're not used to talking about IADLs typically in a skilled nursing environment. Assisted living, care management, home care, those are the venues that typically talk more about IADLs. In fact, in some centers, when you say IADL, they're not quite sure what you're talking about until you say the I stands for independence. So how are they able to do those kinds of tasks that make people safe to live alone? Now, maybe they were able to do it, but maybe they had a pillbox. So they needed some assistance from another person. So I have a pillbox, then I go back and look at the coding and I say, well, I needed some assistance. The resident needed partial assistance from another person to complete the activity. What was that? The other person helped them to establish their pillbox. Maybe there was reminder set on a phone. Many years ago when my dad still lived at home, I used to tease my brother because, my father was very proud that he lived independently at home in his late 80s. Well, he really didn't. He really lived in an assisted living that wasn't staffed with people, but kind of technology and support. So he had pillboxes that were made with him. And then he had a phone call to remind him, because he was very compliant, to go to the kitchen, open the pillbox, and it's 12 o'clock at noon, open up the green level, because that's the one that has your lunchtime pills in it. So we have to consider those kinds of things and find ways to talk to the resident and their family members, because at some point, particularly with a spouse, they're so used to doing those activities that there could be a little bit of a blur. Perhaps in the more traditional families where perhaps the wife is used to cooking the meals and she always laid out the medications, not because her husband couldn't take them, but because, she just did it. It's breakfast time and, she laid out both of their medications for breakfast, as opposed to, my husband couldn't lay out his medications for breakfast. So those are things, as opposed to my husband could fill his pill box. So those are some of the things that we really have to have that conversation, and making sure that the person that you're speaking with really does have an understanding of what you're trying to accomplish. Now, the coding scale, as we look at GGO 100, relates again to the amount of human assistance. And you'll see that the word human is in there. So again, if we say independent, we gave it a 3. The resident completed the activity by him or herself, and nobody had to offer any assistance whatsoever, no human helper at all. As opposed to a 2, where the resident needed partial assistance from a human helper to complete the activity, regardless of what the activity was. And then, of course, dependent, where the helper completed the activity for the resident. I find that when we talk to our staff, talk to the resident or the family member, that we sometimes have a hard time getting them to differentiate between 1 and 2, which isn't that uncommon with the problem that sometimes I think we all see in Section G when we're talking to our direct caregivers between limited and extensive. So you have to make sure that, for effective communication, the person understands the question you're asking. They understand the intent of that question, to help work with you and your husband so that he would be safe to return home and that he could be able to do what's necessary to do so. So those are things that communication part is really critical. We have done, between our RAI team at RB Health Partners, we have audited either remotely for people that have an full electronic health record and or in person that want a staff quiz. We have reviewed thousands of MDSs already, and we're only in the middle of October since the changes. And we have found quite a bit of difficulty in the staff at the center understanding or demonstrating the ability to support the person that's got to answer the question. So it seems like I've a little bit labored on the point, and the reason why is because the information was so inappropriate that it reduced the amount of support that they would have been able to get from therapy had it not been corrected. Because therapy needs to help that person return to that prior level. So that's important. So maybe I have a spouse who lays out the pills for her husband typically, but except for days that she doesn't feel good. She's got rheumatoid arthritis, and once in a while she doesn't feel good, and her husband is physically capable of doing that under normal circumstances. But now, related to his deficit, related to maybe his acute illness, he's not able to do that. Well, when the spouse caregiver said, oh, I do that, because she does do it 75% of the time, but she doesn't include that 25% of the time when she's not feeling well, her husband doesn't, and now he's not able to do it, that becomes an area that we're not going to be focusing on to help him return to that prior level of function because it wasn't identified. So that's why that becomes really important. So I think it's worthy of looking in the RAI manual on pages GG-2 through 4 because there's some great coding examples and the rationale for those examples that I think would be a really good activity that you might do at the center level to be able to look at that. So again, we look at self-care, the resident's need for assistance or bathing, for dressing, for using that toilet, consuming food prior to. And again, just because somebody prepares something for you typically, but the resident was able to do it and did do it in that prior period, we need to make sure that's captured. And of course, we look at, again, indoor mobility, we said, the use of stairs. And we have a lot of residents that don't think about the stairs outside of their home. So you'll notice it has internal or external stairs. And so that becomes really important. And so residents who have external stairs that have to be traversed for them to get inside their home, need to be identified. I have noticed that even prior to the changes, but included with these ongoing changes, that I've seen a bit more of rehab home visits because of really looking at the external stairs and the residents' abilities related to that also, based on capturing that information during GGO 100. So those are things that you want to think about because, again, if you're not capturing that the person could go up the stairs before they got admitted to your building independently or with some assistance from another human, and now we haven't discussed it at all, then there's no reason for that to be part of the therapy rehab plan, is it? Or if it is, it may not be part of the therapy reimbursed rehab plan. So those are things to think about. So the new item in section GGO 110 was the prior device use, coding based on an assessment of the resident's function, of course, prior to the current illness, exasperation, or injury. And so the same information sources as GGO 100, but looking at any mechanical, sit to stand, stand and transfer full body lifts. There are many people that live outside of a skilled nursing facility environment that have some kind of mechanical lift that helps their caregiver. In fact, it was interesting because I was talking to somebody that has a person that lived in their private home for many years, and they're looking at possible nursing home admission, and they were using a variety of mechanical devices in their home to help their loved one. And the center was so surprised that they were doing that. But the sit to stand, I also see a lot of that pivot. There's a particular device I've noticed has been referenced on several occasions where the person requiring the care will stand on it, hold on to the top that sort of looks like a pogo stick, but the bottom is circular and on wheels, and they use that to pivot, particularly for people that have really bad osteoporosis, osteoarthritis, or for whatever reason are prone to fractures, to avoid them pivoting and crossing the bones. So things, all walkers of all types are also to be included. So we look at, again, of course, a manual wheelchair, a motorized or electronic scooter or wheelchair, the new mechanical lift, the walker, the orthotic prosthetics, and if there's none of the above. So we only code this at the start of the SNF PPS stay. It's the only time we need that information. Now, we look at the activity not attempted code can be used for discharge goals. So if the resident declines. Now, when you have a resident that refuses or declines to do something, it's always encouraged to make sure that before we accept that as the answer, we remind them, of course, it's their choice to accept or decline something, totally up to them. But what we'd like to understand is what made you decide not to do it. If it's not applicable, we want to note that as well, or not attempted. Maybe the resident did not perform the activity prior to the current illness, so it wasn't something to be evaluated. Not attempted due to environmental limitations is the new one, as you can see, and that might be related to a lack of equipment. We didn't attempt to use a mechanical lift because we didn't have one. Maybe there were weather constraints because for those of you such as where you live, and us too in Florida, but a little bit differently, there's different weather constraints that might have come up. You know, extreme heat might make a person, particularly who doesn't do well with heat tolerance, but especially folks with COPD or other respiratory illness, don't tend to do very well. People with multiple sclerosis, for instance, don't tend to do very well with extreme heat. So there's things like that. Or it might not have been attempted because of the person's overall safety concerns or their medical condition. So the clarifications that were added was to apply both GGO 130 self and GGO 170 mobility in the steps for assessment. And that's where CMS had anticipated that the interdisciplinary team of qualified clinicians is involved in assessing the resident during the 3-day assessment period. So it's not assigned to, okay, therapy is going to be the only one to do this or not. And they define a qualified clinician based on since now used throughout the guidelines as healthcare professionals practicing within their scope and practice and then consistent with their state and federal guidance. So based on practice acts, You may find that different healthcare assistants are providing different levels. Now, a clarification, the GG0310A related to eating, food and or liquid added to the task description. So the rest is the same, assessing eating and drinking by mouth only. Assistance with the tube feeding or TPN is not included, and I know people tend to make that mistake and try to include it. For residents who have a combination of oral and tube feeding, the eating, of course, is going to be coded based on the amount of the assistance that the resident does require to consume anything by their mouth. If the resident eats finger foods with his or her hands, we're going to code based on the amount of assistance that's provided, not the fact that they're not using other utensils besides their fingers. We look at toileting hygiene, and again, in the task description, added verbiage that item pertains to both voiding or having a bowel movement, and that becomes really important. Hygiene tasks can place before and after use of the toilet, commode, and bedpan or urinal, and obviously if the resident has indwelling urinary catheter, bowel movements, coding the toileting hygiene based on the assistance that's needed by the resident. So also new, we're going to look at GG030 new items. We have self-care functional abilities related to shower and bathing themselves. The ability to bathe themselves, including water, washing, rinsing, drying, and it says to exclude washing of back and hair. Does not include transferring in and out of the tub for GG030E rather. Then it goes into F, looks at upper body dressing. So how can the resident undress or dress above the waist? And that is going to include if they're fastening. So if they have a shirt that requires fastening, for instance, for above body dressing. Then we look at G, which is lower body dressing. And again, how to undress or dress below the waist. And that includes the use of fasteners. It doesn't include footwear because that's an H. And the ability to put on and take off our socks and shoes or other appropriate footwear for safe mobility. And that's going to include the fasteners that are used to accomplish that as well. Now, when we look at section GG, when we look at 130E and F, the new item, I know that you've probably looked in the REI manual, but sometimes people don't focus on that, but the examples are really very strong. So if we look at showering and bathing self, reading the entire description in order to code accurately is key for those of us that have done the REI for many, many years. So we may be on the phone with people like myself who have been involved in the MDS world since 1990. It's a long time. Coding directions have really changed a lot in that period of time, and especially the last 10 years have really changed dramatically. So making sure that we're really reading that. If you are a very experienced RAI coordinator, or you're employing one, or you're just interviewing somebody, making sure they're using their manual. When we do the assessment, it can take place in the shower or the bath, at the sink, or at the bedside. So if someone's doing a sponge bath, that's fine. Upper body dressing that we're going to look at, if they wear a brassiere, if they wear an undershirt perhaps, if there's buttons, if it's a shirt and it's a pullover shirt, dresses, sweatshirt, sweater, nightgown, but not a hospital gown. And of course, pajama tops as well. Other examples might be things like braces. You might have a stump sock or a shrinker, something to support the neck, a prosthetic or orthotic device, the thoracic, lumbar, sacrum orthotic. Things of that nature are going to be considered. And then helper assistance with buttons and or fasteners is considered when we talk about touching assistance. So not necessarily weight bearing, but touching assistance to help them with that zipper, for instance, or those buttons. Now, when we look at additional new items, when we look at 0310G, the lower body dressing, again, the helper assistance with the buttons or fasteners is considered that touching assistance I just mentioned. And sometimes the staff have a lack of understanding about the touching assistance. Other examples might be a knee brace, or it might be a lower limb prosthetic. Now, putting on or taking off, which some will call donning and doffing, footwear is going to include, shoes, boots, socks, etc. I see it says running shoes. Haven't really considered that, but I guess a lot of our residents do wear running shoes. Other example, ankle foot orthotics. It might be compression stockings that have to go on and off and go over the person's foot. And also looking at an amputee that may not have footwear as a shoe because they don't have a foot. And you'll see that on page GG-23. Now, when we look at 0170GA, another new item, we look at mobility functional abilities. So the resident's ability to roll, whether it be to the left and or to the right, the ability to roll from lying on their back, sitting on their side, return to lying in the bed. So you might have admitted a resident who's bedbound in their private home, and their caregiver is able to take care of them because the patient's able to roll left and right. But if the resident couldn't roll left and right, then the caregiver, it wouldn't work for them. They don't have a hospital bed. They're in their family bed, and they just wouldn't have the ability to do that. Sit to lying is evaluated, the ability to move from sitting on the side of the bed to lying flat in the bed. Lying to sitting on the side of the bed, sitting to standing, chair to bed to chair transfers, and toilet transfers, which are really important, the ability to safely get on and safely get off of the commode. So those are areas in the new items that are really being looked at to have a better understanding. Now we also look at car transfers. When we look at that, the ability to transfer in and out of the car or the van or the passenger side, whether or not they're driving or they're going to be the passenger. It does not include the ability to open or close the door or put their seatbelts on. And so I see a lot of centers already did, but I've seen a few more add therapy gardens where they actually have a old car that doesn't have an engine in it, and they're actually having people being able to work on that as a skill set because they could get in and out of the car. Maybe their spouse held the door open. They could get in and out. Then maybe the spouse put their seatbelt on them, and that's how they got to doctor appointments, for instance. Then it talks about the ability to walk just 10 feet. Once standing, the ability to walk at least 10 feet, so in a room or a corridor, which obviously that ability to walk that short distance really has a very big impact. Then it looks at a further distance, and it looks at 50 feet and the ability to make turns, as opposed to 150 feet or walking on an uneven surface for up to 10 feet. So walking items do not need to occur in one session, and the mobility items do not need to occur at the parallel bars. And that was a misunderstanding. That was spoken about actually at the CMS Baltimore training quite a bit. Things of that nature were brought up. The ability, and I know if you haven't seen it already, the YouTube videos that MLN has, and the YouTube videos rather, that also exist, are really very beneficial and helpful to looking at that. And it's really important that we're all very consistent, and that's really important to make sure that there's a consistent understanding at your center. The ability to go up and down a curb and or up and down one step is being looked at. The ability to go up and down 4 steps with or without a railing present. If admission or discharge performance was coded at either a 7, a 9, a 10, or an 88, then you're going to see where you skip. The ability to go up and down 12 steps with or without a rail. And remember, we have to think about, people who have external stairs as opposed to internal stairs, or they have both or none at all. The ability to bend, stoop from a standing position in case they need to pick up an object that's rather small, such as a utensil from the floor, could also occur if the resident is upright in their wheelchair. Now, mobility function abilities is also looked at, and this slide and the next two display how these items are going to be labeled differently from the admission performance 1, discharge goal 2, and or discharge performance 3 based on those skip patterns. If I look at admission, does the resident use the wheelchair and or a scooter on admission? If we say no, then you're going to see the skip pattern that takes us all the way over to GG0130 for self-care for discharge. If we say yes, then we're going to go over and say, okay, can the resident wheel 50 feet? and make 2 turns. Now, when we get to the discharge, does the resident use a wheelchair and or a scooter? If we say no, then it takes us to appliances. But if we say yes, then again, you're going to see wheeling 50 feet with 2 turns as you did above. Now, as we look at once the resident is seated in their wheelchair or their scooter, their ability to wheel at least 50 feet and make 2 turns, as opposed to indicating the type of wheelchair or scooter that's used, whether it be manual or it be a motorized one. And then obviously for discharge, same. Is it going to be a manual or is it going to be a motorized wheelchair, assuming that one is going to be used? So we look at that. So some general coding tips that we wanted to include in today's webinar. Admission performance and discharge goals are coded on every admission assessment as the start of the Part A PPS stay, regardless of how long the stay is and whether it's a planned or it's an unplanned discharge. That has seemed to be bringing up some questions of late. If the resident has an incomplete stay, then we're going to do discharge, self-care, mobility performance items are not going to be required. So if we look at an incomplete stay, GG0170 mobility, the 3-day assessment period, we're going to look and see that it says mobility assessment period is the last 3 days of the center PPS stay, ending on what we code on A2400C. But we're going to complete only if G is not a 2 and or H is not a 1, and if C, we're going to look at that to determine as well. So we're going to look at that. Now, obviously, we need to consider our QRP and what key points that we need to consider. So as we gathered that information, we looked at, for the quality reporting program, a minimum of 1 self-care mobility discharge goal had to be coded. And that really has been a sticky issue for some centers. However, facilities may choose to complete more than 1 if it's appropriate to do so. So coding the resident's discharge goals using that 6-point scale. Use of the activity was not attempted. Coding 7, 9, 10, as you can see, 88 are permissible on the code for the discharge goals. We know that the dash is permissible for any remaining self-care mobility goals that were not coded. And of course, we understand that at least 1 discharge goal must be indicated for either self-care or mobility, and that using the dash in this allowed instance after the coding of at least 1 goal is not going to affect your APU or the annual payment update determination. So sometimes that dash, if it's not authorized, obviously that is going to have a negative impact on the APU, but that doesn't mean that all areas aren't going to be authorized. Now we look at section GG and we look at the wheelchair items. And the intent of the wheelchair items is to help assess the ability of the residents who are learning to self-mobilize using a wheelchair, or who used a wheelchair before they came to your center. Use a clinical judgment to determine whether a resident's use of the wheelchair was for self-mobilization as a result of the resident's condition or safety, as opposed to, say, convenience. So don't code the wheelchair mobility if the resident uses a wheelchair only when transported between locations within the facility. So when they're in their room, they're on the unit, but then we are using it to take them to a faraway dining room. Admission assessments for wheelchair items should be coded for residents who used a wheelchair prior to admission. The responses for the gateway admission and discharge wheelchair items do not have to be the same on the admission and discharge assessments. I have noticed in some auditing that people have had the misconception that they did need to be the same, and that's not true. So remember, the prospective payment discharge assessment has got to be done timely, and it has to be submitted timely. CMS does look at the MDS items that not only go into the calculation of the numerator, but also the items that are used to calculate the risk adjustment covariance. That's really important. And a minimum of 1 of the potential discharge goals must be coded on the 5-day assessment to count towards that threshold of 80%. So if that's not there, then you're not going to have that. If you code yes in A0310H, whenever any type of discharge MDS is completed, planned or unplanned for the Medicare stay, you're going to note that. So we're going to code yes there. And we're going to complete a standalone PPS assessment for Part A discharge assessment when a resident's Medicare Part A ends and the resident stay in the facility for more than 24 hours after the last covered day. So that's a big key point to remember. So if you wanted to look at that on the MDS itself, you would see an A0310H, the question where the little red arrow should point, hopefully, so you can see that better. Is this a SNF Part A prospective payment system discharge assessment? And so you want to make sure that's properly added. So we look at another handout that you may want to look at, that ANAC has also used public domain information, and I'm an ANAC member as well, and that's why I'm able to use this information as well. But helpful resource to determine the elements needed to calculate that is on that web link. And before we sent this to you, I always make sure that we check and make sure the web link is still live. Sometimes they change web links. It was, as of last week, it was still a live web link. If for some reason any of the resources that we have included, if you find something's not live, if you just email me that, I'll make sure that I forward you a live link with apology and make sure that you have that. So when we look at the QRP fiscal year, FY standing for fiscal year 2020. And so the work we're doing now is looking at 2020. So, and that's something that I don't think has been as well understood in the centers, is that we're creating tomorrow's information, not the immediate tomorrow, but tomorrow's information. So January 1st to September 30th of 2018, we know that it got replaced on October 1st, 2018, and that related to new or worsened pressure ulcers. And you can see the impact of the reduction on the APU related to that. Now, changes in skin integrity and for pressure ulcers and injury was effective October 1st in our changes. One or more major injuries you'll see for January 1st through December 31st of 2018, as well as the admission and discharge functional assessment and that POC. And that's going to impact on the fiscal year of 2020 based on information from 10/1/2019. So the drug regime, when we look at that in the follow-up issues, if we're looking at those areas there, the outcome measure for the change in self-care score, if we look at the outcome measure related to mobility score, the outcome measure related to self-care, and or the outcome measure related to discharge mobility, effective October 1st, 2020, impacting 2% reduction to the APU fiscal year 2020, effective October 1st, 2019. So when we look at the skilled nursing facility URP 2020 fiscal year measures, we want to try to remember that access and assess the confidential feedback reports for assessment claims-based information. If you're not looking at that and you're not accessing that and then assessing or evaluating it, that is an area that you need to start. And so those analytics are very important. If you're part of a group or chain, you probably have corporate or management oversight support that's doing that. If you're part of an individual or very small group, you may not have that analytics. And so, obviously we're consultants. Washington has lots of consultants. If you're 100% remote electronic health record, anyone can do it from you from any location. But you want to look at, are you looking at these analytics based on the information that you're coding so that you can financially plan from a budget standpoint where you're going to be in time to come? We want to review the measure specifications to have a better understanding. So are you looking at the technical guide and reviewing what makes that measure response? It's not hard to review, but I understand if you're, got a full-time job being the MDS coordinator and a full-time job being the administrator and the director of nursing, you might need help. So if you're within a group, please ask for that kind of help. Whoever owns or operates your center, you want to ask them what kind of support you can have, because otherwise it's gonna catch up on you. And those are areas that need to be looked at. The deadlines are really important, and that means you got to submit timely. And so we've been working towards a lot of this for many years, but those are things that really have to be focused on. Now we're going to go look at Section K. And so when we look at Section K, we know we're looking at while not a resident, and you can see that that's bolded. And the mechanically altered diet, where we require the change in texture of the food or the liquids, meaning that maybe the liquids are thickened or that there is a different texture, such as puree, as opposed to a therapeutic diet, which would be, if you had some kind of diabetic or low cholesterol. Now, hopefully, I noticed that CMS gives these examples, but then in another area of the rules of participation, CMS talks about, the ability, when appropriate, to liberalizing diets. So it's kind of interesting, but, being able to evaluate the therapeutic diet. CMS does not consider completion of column 1 for KO510C and KO510D. It's not required by state, and you just have to use a dash. So not every state requires that to be done, and if you don't have to do that, a dash would go there, and that would not be held against you. However, of course, you need to review your state requirements. Now, in Section KO710, we're looking at the percentage of intake by artificial route, the proportion of total calories received through parental or the enteral tube feeding. And then in KO710B, looking at the average amount of fluid intake either by the tube feeding and or by the intravenous. CMS does not require completion of while not a resident in column 1 unless your state does. So the alert that's here is just many Medicaid RUG states and Medicare Part A RUG 4, you need the completion of that. So you do need to make sure that that's state specific and appropriate. Now let's talk a little bit about the cause and the care area assessment variances in Appendix C. The update to review of the indicators. With that, we look at behavioral symptoms, seriousness of the behavioral symptoms. And I believe that this section, based on what was said over at the Baltimore training, took a look because it seems that nationwide, the number of residents with behavioral disturbances in our centers has increased, whether they be physical behavioral symptoms directed towards others, verbal behavioral symptoms directed towards others, other behavioral symptoms not directed towards others, behavioral significantly interferes with the resident's care, the behavior that significantly interferes with the resident's participation in their activities or their ability for social interaction, behavioral significantly intruding on the privacy of others. That's very important. And actually, many of these can, as we indicate these and determine these, ultimately can have a severe regulatory impact as well. Behavioral significantly disrupting the living environment that the resident is physically in, resident who rejects care that is necessary to achieve his or her goal, or resident behaviors that either include the rejection of care or wandering that has gotten worse. It's the last assessment. These are all factors that we know that can worsen behavioral issues. You'll also notice that alarm use is included in that as well. That question that was added in PO 200 prior to October 1st. Now let's consider the Impact Act on all this. We know that Improving Medicare Post-Acute Care Transformation Act of 2014 was CMS said to modify the post-acute care patient assessment data that is required for submission to CMS. And that had an impact on payment, an impact on the quality measurements, but it also had a big impact on the state surveyor process. I know you probably remember before the new survey process rolled out in November 27th of 2017, that around the country, I'm sure you heard about the different demo states for the different kinds of focus surveys. There was the MDS Staffing and Compliance Survey, there was the Infection Preventionist one, There is also the dementia one. And the dementia assessment survey process looked a lot at behavior, and that's why I circle back and referencing that. And there have been a lot of changes in the state surveyor processes related to behavior. Now, as we tie it back to the SNF QRP, we look at that 2% cut. Submission of all data to calculate the SNF QRP measures on at least 80% of the MDSs. It looks at subsequent years. And did we fail to submit all required QM data subject to a 2% reduction related to that APU? So Section 1, summary of the changes. We had new items that were added on the 5-day PPS, and the reason specifically why that Baltimore discussed was the QRP requirement. The risk adjuster that was added for the 4 new QRP SNF quality measures that focus on functional outcome quality measure, and then the chosen category is to be the most indicative diagnosis as the reason or the reasons that they were admitted to the SNF and can have a significant effect on the functional improvement of that resident, which means you have to go back to page I-3 in Chapter 3 of the RAI manual for active diagnosis. Now, the RHIT, the Registered Health Information Technologist that I work with at RB Health Partners, happens to be a certified coding specialist. So she's an ICD-10 expert. And when she was giving in-service to our RAI team at RB Health Partners, she spent a lot of time working on that because in her auditing and evaluation, we have a lot of people that have, I call them carryover diagnoses. Sometimes people think the newer diagnosis is active just because it's newer. So maybe last year somebody had a car accident, and when they had a car accident, based on their head trauma, they had a stroke. But they have since subsequently fully recuperated from that stroke well more than 90 days ago. Well, that's not going to be an active diagnosis. It is status post that they had a CVA, and the CVA was related to the MVA that they had that resulted in head trauma. But do they currently have an active diagnosis? No. On the other hand, you might have someone that has malignant hypertension. And 20 years ago, due to malignant hypertension, they had a CVA. And they still have malignant hypertension. It's being treated with medication. The nurses are assessing the blood pressures on a daily basis. And there are parameters that get followed. And if there's a variance of those parameters, doctor gets notified. That remains an active diagnosis, even though it's 20 years old. So the ability to have an appropriate active diagnosis does come in. Section 9, when we look at that primary medical condition category, and that's, of course, so that we can do those risk adjustments. So I used 01 as your first example, which was stroke. But you can see that there's stroke, there's a non-traumatic brain dysfunction. You can go through and read those, and you can see that these are the areas that indicate the resident's primary medical condition category that best describes the primary reason why the resident was admitted. So if I go back to my example, yeah, they had a stroke a year ago, status post MDA, but the reason why they were admitted is they had acute pneumonia, and that's why they went to the hospital, and that's why they were then admitted to our skilled nursing facility, because that acute pneumonia caused subsequent changes. So the CVA that happened a year ago is not why the person was admitted, was it? And that's what this is trying to help us to do. Now, coding directions, like we talked about, are important, and we're only going to complete only if A0310B equals to 1, the start of the Part A prospective payment system stay. We're going to enter the code that represents the primary medical condition that resulted in the resident coming to the admission to your center. And if codes 1 through 13 do not apply, then you're going to put in a 14, which stands for other medical conditions. And then you're going to proceed over to I0020A. We're going to include the primary medical condition, then again as coded, in what's called the active diagnosis in the last 7 days. And when you look on page I-3 of the RAI manual, all but urinary tract infections have a process that we're supposed to engage in. So you'll see the coding directions, and here's an example. Let's take traumatic brain dysfunction. The examples are going to include traumatic brain injury, severe concussion, and cerebral laceration and contusion. So if we are going to code 03, those reasons I just reviewed in the examples would be why. If we were to code O1, which represents stroke, then we would say the example includes an ischemic stroke, a subarachnoid hemorrhage, a CVA, and or other cerebral vascular disease, because a stroke is not a stroke is not a stroke. So obviously we want to know that. And that's important to know if the person's at risk for subsequent strokes or not, and or the kind of damage and whether or not it's going to cause ongoing decline or not. If we looked at code 6 for an example, progressive neurological conditions, it might be things like Parkinson's disease, it might be stiff man syndrome, it might be multiple sclerosis, etc. So as you can see, as we decide what we're going to code, we're going to get examples. They're not exhaustive examples. You might find others, and you're going to find that by using, hopefully, your ICD-10 coding book is going to help you with that. If you were to say amputation, for example, you'd say the acquired absence of a limb. So there's a coding definition in your ICD-10 book, for instance. Hip and knee replacement, for example, total knee replacement. If the hip replacement is secondary to a hip fracture, then we're going to code it as a fracture. So that's where sometimes it gets a little confusing, and that's where that proper coding is key. If we look at other orthopedic concerns, it might be things that are unspecified disorders of the joint. If we look at debility or the cardiorespiratory conditions, we're going to look at things like I mentioned earlier, COPD. It could be asthma. It could be malaise and fatigue, things of that nature. As opposed to complex medical conditions, where we're going to look at diabetes, pneumonia, like I mentioned earlier, chronic kidney disease, open wounds, pressure ulcer injuries, infection and disorders of fluid, electrolyte, and those of the acid-base balance. So we're going to make sure that we're really following the coding directions, that we're properly identifying the active diagnoses that follows the ICD-10 guidance, as well as what we receive reflected on page I-3 and in that section of the MDS. Now, a couple practice scenarios are included because, to be honest, this is an area that we've seen a lot of opportunity, to be honest. So we'll take Mrs. K. She's a 67-year-old female, and she has a history of Alzheimer's disease. She's also diabetic, and she was admitted after she had a CVA. The diagnosis of the reason why she was admitted of stroke, as well as the history of Alzheimer's disease and diabetes, is going to be documented in Mrs. K's history and physical by the admitting physician. However, what are we going to code on in the MDS? And so we're going to indicate the primary medical reason why the resident came. So what did you put? Did you put stroke? Did you put a non-traumatic brain dysfunction or medically complex condition? And we're going to indicate the primary. So let's look at another one. Mrs. H is a 93-year-old female with a history of hypertension, as well as chronic kidney disease, who is admitted to the facility where she will complete her course of intravenous antibiotic after she had urosepsis. The discharge diagnosis of urosepsis and chronic kidney disease, as well as hypertension, are documented in the physician's discharge summary from the acute care hospital, and they're incorporated in Mrs. H's medical record. So we have to think about how we're going to code as her primary admission diagnosis. Let's look at another example, Mrs. T. She's an active 83-year-old male, Mr. T, excuse me. He fell from a ladder while he was changing a ceiling light bulb in his house. And when that happened, he experienced a left intercapsular hip fracture, and he had to have a hip replacement. So remembering what we said earlier, the discharge diagnosis of status post-hip fracture with the THR is going to be documented in the physician's diagnosis. So he's admitted to the skilled nursing facility for rehab. So how do we code him? For the hip fracture or the replacement? So think about what we just talked about. Now, when we look at the QRMT, and we had handouts that I had forwarded over for that, we want to remember the possible 2% reduction in the facility annual paperwork. Coding the risk adjusters is just as important as coding the triggering items on the MDS. So the functional outcome measures is looking at the change in self-care score, the discharge self-care score, the change in the mobility score, and the discharge for the mobility score. All is very important. Now, when we look at Section J, the new item is about prior surgery. So J 2000, did the resident have a major surgery during the 100 days prior to admission to your center? If you say yes, another risk adjuster for the 4 new SNF QRP functional outcome measures. Ask about the history of major surgery during the 100 days prior to admission. So we should be asking that as standard admission questions. Criteria for major surgery has to be met. There are 3. The resident was inpatient in an acute care hospital for at least 1 day in the 100 days prior. The resident had general anesthesia during the procedure, and the surgery carried some degree of risk to the resident's life or the potential for severe disability. So we have to make sure that we have a method to ask that. Now, when we look at Section M, effective this October, we see that there's a modification. And that was the determination of the pressure ulcer injury risk. We mentioned that earlier. And we looked at the risk of pressure ulcer injuries, and then we look at the unhealed pressure ulcer injuries. Now, when we look at skin conditions, we know that the date of the oldest stage 2 pressure ulcer updates removed several MDS items. It removed the dimensions of the unhealed 3 or 4 pressure ulcer or unstageable due to SCAR, or the most severe tissue type of pressure ulcer, worsened in pressure ulcer since prior assessment, and healed pressure ulcers. Now, you might think that, these are pretty important areas. And although these items are no longer included in the MDS information, important for wound tracking and monitoring should be done at the center level, but it's not going to be tracked by CMS on the MDS level. Now, there were some updates to definitions, and one of them was healed pressure ulcer. Completely closed, fully epithelialized, covered completely with that tissue, or resurfaced with new tissue, even if the area continues to have some surface discoloration. So making sure that we recognize that healed pressure ulcer as opposed to thinking that we're still considering it an active pressure ulcer. Pressure ulcer injury risk factor also was looked at, and the example risk factors included immobility and decreased functional ability. The comorbid conditions are very important, such as the end-stage renal disease, diabetes, thyroid disease, use of various drugs such as steroids, issues related to blood flow, a resident who declines skin and treatment, so skin care or treatment, cognitive impairment that exposes of skin injury and or such as fecal incontinence, and then you'll see the microclimate, which is the air temperature, humidity, airflow at service of the support service. So if you're using a specialty bed, etc. So those are areas that we needed to look at. Based on that, coding tips that needed to be considered if the resident had a pressure ulcer injury that healed during the look-back period of the current assessment, then you're not going to code the ulcer injury on that assessment. I have definitely seen that one not done correctly of late. If 2 pressure ulcers occur at the same bony prominence, but they're separated at least superficially by skin, then you're going to count them as 2 separate pressure ulcers, and you're going to stage each one, and you're going to measure each one. And I know based on debridement and other issues that there might be a point that maybe those 2 become one, and I know that that's always been a concept that many people have shared. However, the coding tip makes sure that we recognize them and code them separately. Now, the additional definitions, when we looked at granulated tissue, it said red tissue. The addition was cobblestone or bumpy appearance, and it bleeds easily when injured. The epithelial tissue is new skin that is light pink and shiny, even in persons with dark pigmentation. In the stage 2 pressure ulcers, the epithelial tissue is seen in the center and at the edges of the ulcer. In full thickness 3 and 4 ulcers, Epithelial tissue is usually at the edges of the wound. And a reminder, if you're looking at a wound, remember the deepest point for measuring purposes is typically in the center. Now in section M, O300, unhealed pressure ulcers, ulcer injuries, updates, modified MO300 items for clarity and accuracy. Determine the deepest anatomical stage. The pressure ulcers do not heal in a reverse sequence. I know that years ago there was that thought process, but obviously that's changed over the last several years. That's certainly not new. And that means because the body doesn't replace what level of tissue was lost. If you lost fat and dermis, then that's not going to be replaced. It's going to have scar tissue. Stage 3 and 4 pressure ulcers fill with granulation tissue. This replacement tissue is never as strong as the tissue that was lost, and that means they're more at risk for re-alteration of skin integrity, which means the center has to identify that risk and put a plan in place to avoid the subsequent reoccurrence of that alteration of skin integrity, and or if not risk, having an in-facility developed wound maybe a year after it's been healed, for instance. And while the person might be at risk, the surveyor would be reviewing what did the center put in place to reduce or minimize that risk so that reopening would be less likely to happen. How does that get communicated on the plan of care? How was that identified in the care area assessment, et cetera? Those are things that have to be looked at. So we know that clinical standards do not support backstaging or reverse staging as a way to document the healing, as it does not accurately characterize what is occurring physiologically as the ulcer heals. So it's more of a description. So they want us to determine on MO300 present on admission. Now this is a challenge. A lot of people have wound care nurses. They typically work either 5 days a week. They might work 7 days a week, but they're not there all the time. And because many centers report getting admission after hours, certainly after 4 o'clock in the afternoon, that there's a high probability that the person who's doing the admission is also the person who's the designated charge nurse for that wing, and they are more apt to miss the presence of alteration in skin integrity. So if the pressure ulcer was present on admission, and you really want to make sure a really good head-to-toe skin check is done, that there's good lighting, perhaps a flashlight is used. We want to make sure that we look at some of the problem areas that may be less visible because of extra folds of skin related to weight, etc. But we want to make sure that this is necessary, that we recognize it. If on admission we recognize something that's unstageable due to slough or eschar during the resident stay, then we want to be able to note that as well. And so we want to make sure that we've noted what was present on admission. So there's some examples that are really exceptional in the MDS book. I thought they did a nice job of clarifying that in Chapter 3, and those would be on pages M-9, 17, 18, and 23, and I encourage you to review that. When you look at M1040, other ulcers, wounds, and skin problems, we're looking at open lesions that develop as part of a disease or a condition are not coded elsewhere on the MDS, such as wounds, boils, or cysts. They should be coded in this section. So, you know, a pressure ulcer is a diagnosis. Diabetic ulcer is a diagnosis. A cyst is a diagnosis. That means it requires an ICD-10, which means a physician or a physician extender appropriately credentialed by the state are the only ones allowed to identify that. So you want to make sure that you review this information and that you get a proper diagnosis to support where you coded the information on the MDS. And you want to make sure that you don't code rashes and abrasions in this area. And you want to make sure that you don't code pressure ulcers in this area because these are for non-pressure related areas. Now, M1040G is skin tears. And skin tears, we know that can be a result of shearing, friction, or trauma to the skin that causes separation of the layers of the skin. So we don't want to cut lacerations here. We don't want to code cuts, lacerations, or abrasions here. Although they may be recorded on the MDS, these skin conditions should be considered also in the plan of care. Again, once you've identified, for instance, if someone has very thin tissue, maybe they've been on long-standing use of steroids, for instance, or they're at very advanced age, The skin is the largest organ of our body. So I have a 99-year-old, and they have very translucent, thin skin, and it very easily can be, whereas a normal person who's maybe 85 with regular skin turgor, they bump their hand, maybe they get a bruise, maybe they don't, but they rarely would result in having a skin tear. And this person with their very advanced age and translucent thin skin, maybe they're more prone to do that. That information should be properly identified because CMS wants us to recognize it in the care area assessment and then it carry over to the plan of care so that we can put a plan in place to protect that resident, right? Part of the 7 abuse, when you think about the 7 abuse requirements, neglect, failure to provide goods and services, et cetera, we want to make sure that we've identified that risk and that we've done something about it. Now, the definition of moisture-associated skin damage, we know that that was added to the MDS a period of time ago to add a risk factor related to injury. So perhaps, again, maybe in the person who might be morbidly obese who has excessive skin folds. It could be a thin person that has excessive skin folds because they lost quite a bit of weight, for instance. It's that superficial skin damage caused by sustained exposure to moisture, such as incontinence, wound exudate, or perspiration. So that could easily happen, and that puts that skin at bigger risk. And that not only just to have alteration in the integrity, but also cause some pain and discomfort. M1200, where we look at skin and ulcer injury treatment, that's about the application of non-surgical dressings with or without the topical medications other than to the foot. So only addition was that there would not be counted non-surgical dressings such as Band-Aids, bandages, and wound closure strips. Now, it's interesting about this. I have seen in the last 30 days in 2 different states the facilities getting cited related to Band-Aids. So I would encourage you to look at the NP-UAP website guidelines for staging of wounds, but also they had something on the guidelines that also talked a little bit more about Band-Aids, bandages, and wound closure strips. So you may want to look at that. In Section N that was added in the 5-day PPS, we're going to look at to calculate a new SNF QRP quality measure. And that we're looking at drug regime, medication follow-up, and medication interventions that we're going to look at. So October 1st, we looked at N2001, 3, and 5. Now, the intent of this drug regime is to document whether or not the DRR was conducted, starting at the skilled nursing facility prospective payment system stay, and also throughout until discharge. And then if there was any clinically significant medication issues that were identified. So the use of polypharmacy is really being examined aggressively by CMS, whether that relates to inappropriate antibiotic usage and whether or not the center has adopted appropriate antibiotic stewardship, such as perhaps using the McGeer criteria, the appropriate use of psychoactive meds and specifically antipsychotic and other behavioral medications, could be the overuse of other medications that are not found to be appropriate because of the realignment of the actual diagnosis and conditions based on the active disease and diagnosis listings that are getting done. So Section N really has a lot to look at. Now, the definition of the DRR, or the drug regime review, includes medication reconciliation, a review of medications the resident is currently using, and a review of the regime to identify and, if possible, prevent the potential clinically significant medication adverse consequence. Just about all medications have a side effect. Yes, they're used for a particular reason, and that's great. I think we see that all the time now when you look at the TV and there's all these commercials for some of these medications for people that have a variety of chronic medical problems, and it's kind of an interesting because they have this great commercial and this very happy person who's getting all these wonderful outcomes, and then there's that other voice that tells you about the side effects, including all the medications prescribed and other counter nutritional supplements that are being listed, as you know, and then also looking at TPN and also oxygen therapy. So new drug regime review did a complete drug regime review, potentially clinically significant medication issues. Did they identify them as, nope, no issues were found? That's great. Then you're going to skip. Yes, issues were found, and then we're going to continue on. And non-applicable, the resident's not taking any medications, which would probably be rather rare. Only complete PPS 5-day assessment. So steps for assessment, we want to look at the DRR upon admission or as close to the actual time of admission as possible. Many centers report that they're doing an off-site pharmacological review during the admission process now, that their pharmacies are using a software and consultant pharmacist review process remotely being done, which is great. Identify any potential or actual clinical significant medication issues. So a lot of times, especially after hospitalization, a resident was on certain kinds of medications at home, then they make a change to those medications at the hospital, and they had a hospitalist there. Now they come to your skilled nursing facility, and now they have a SNF on board. Maybe that was or maybe that wasn't their doctor at home, and there can be some confusion about what medications the resident should be on. Drug regime review medical records, documentation to determine whether a DRR was completed upon the admission process. If you're one of the centers that is having a DRR that's actually done prior to or during the actual admission process through maybe a pharmacological software program that's managed by the pharmacist at the pharmacy, want to make sure you get credit for that. Medical record sources, of course, they want us to look at medical records received from facilities where the residents received health care. So that means the hospital information, the H&P, et cetera. And then discussions could be with the acute care hospital clinicians responsible for completing the DRR. So as you know, in the rules of participation, we are told that we're supposed to do a nurse-to-nurse or facility-to-facility communication prior to admitting the resident. That would be pertinent information, particularly if you admitted someone, let's say they were on TPN, then the pharmacist that was responsible for evaluating the TPN based on lab, et cetera, at that acute care facility might want to talk to the pharmacist at your facility or the pharmacist that's going to be responsible to be evaluating that at your center. Drug regime review, it has the steps for assessment. Again, number 3 was clinically insignificant medication issues that may include but are not limited to. So here's an example of things. So it might be medication prescribed despite allergy or prior adverse reaction, excessive or inadequate dose, so some black box use, duplicative set therapy. I know I had a resident at a building the other day. They are on 3 diuretics. It is appropriate for them to be on 3 diuretics. So what I recommended that they also do was have the physician write a progress note that explained the medical rationale for the resident to be on those 3 diuretics at that dosaging of each diuretic and why it was clinically contraindicated to make a change. Drug regime review, we look at the coding direction. 0 means no. If no clinical significant medication issues were identified during the DRR, that's great. Yes, if there was 1 or more issues. And 9, if it was non-applicable. The resident was not taking any medications at the time of the DRR. There are potential or actual clinically significant medication issues. So when we look at that for N2001, clinically significant means the effects, results, or the consequences that materially affect and or are likely to affect an individual's mental, physical, or psychosocial well-being, either positively or by preventing a condition, or negatively by worsening or causing or contributing to a symptom, to an illness, or decline in their status. We want to review the DRR information. When we look at the new item, medication follow-up. Now, the process of contacting a physician to communicate an identified medication issue and completing all physician-prescribed recommendations, actions by midnight of the next calendar day at the latest. That's huge. I know a lot of centers will have follow-up for the physician, and it might take a couple of 3 days to get that. Obviously, that's going to be problematic. So if you're having that problem, you're going to need to talk with your physicians and, perhaps the director of nursing, the administrator. It might need to be contractually dealt with if it's the medical director who's causing those problems. And you have a contract with the medical director that separates their duties as a PCP, primary care physician, versus the medical director. And as a medical director, it's going to be their responsibility to help you communicate with physicians that are non-compliant. Just like you might have them help communicate with physicians that aren't interested in following, standards of practice related to antibiotic stewardship. Those are all things that are going to have to be reevaluated. The medication follow-up in N2003, as we look at the steps for assessment, we're only going to do this if one or more potential or actual clinically significant medication issues were to be identified. And if they are, we're going to review the medical record to determine whether the criteria was met. And that talks about the communication two-way between the clinicians and the physician, and then also the physician prescribed recommendation actions and how they're getting done in a timely manner. Many centers tell me that they actually bring them to the next day stand-up meeting, is what they've done. But if that's not a conversation you've had with your medical director yet, you might want to have one, whether he or she may not be doing the best that they can for that, or their nurse practitioner, or that of another physician or physician extender that's practicing in your center. Medication follow-up coding directions, so a 0 if the facility did not contact the doctor, and a 1 if the facility contacts the physician and the completed prescribed recommendation had been properly responded to prior to midnight. The definition of contact with physician is communication with the physician to convey an identified potential or actual clinical significant medication issue, and a response from the physician to convey prescribed recommended actions in response to medication issues. Communication can be in person, it could be on the telephone, it could be electronically. In fact, I know a lot of people's electronic health records even have a HIPAA-protected methodology to test, whatever way that you all are going to do that. Coding tips. If the physician prescribes, recommends an action that will take longer than midnight for the next calendar day to complete, then you can code a 1, which is a yes, the facility has taken the steps to comply. A dash is a valid response. However, CMS expects dashes to be used very rarely. So if as an industry we have a lot of dashes in this area, I'm sure that there will be a change to the MDS section, and it might have an impact on your APU in later dates. Section N, medication intervention, is new. Did the facility contact the and complete physician or physician designee prescribed recommended actions by midnight or the next calendar day, each time potentially clinical significant medication issues were identified? Kind of like a trick question. The answer needs to be yes. If the answer is no, you're going to have to examine it and come up with it. If you find no to things like this, you might find that you're going to bring it to your QA&A committee, and then probably there's going to be the governing body representative, i.e. the administrator, is probably going to request a study that's going to be done by a person or a subcommittee, so that you can then reconvene your QA&A committee, and then you're going to have to bring it to QAPI so that you can evaluate your performance improvement project and how you're going to correct the matter. So make sure you get credit if you're doing all that for writing that out as well. If we look at 2005 medication intervention, completed only the PPS Part A discharge assessment, planning for care every time a potential or actual clinically significant medication issue is identified throughout the resident's stay. It must be communicated to a physician, and the physician prescribed recommended actions must be completed by the clinician in a time frame that maximizes the reduction in risk for medication errors and, of course, for resident harm. So you'll see the steps for assessment, starting with the observation period, reviewing the record, determining whether the following criteria was actually met for any potential or actual clinical significance. So they're looking at the two-way communication between the clinicians and us, and the time frame that got done by, and then, of course, the physician prescribed recommended actions that were completed by, again, midnight of the next calendar day. And then coding directions. The facility did not contact the physician. I don't know about you. I'm not looking forward to coding that, right? As opposed to, yes, the facility contacted the physician and completed the prescribed. I'd like to say that. Or non-applicable if it wasn't applicable. Now, in the SNF QRP drug regime review, you're going to see the SNF numerator is the number of short-stay residents with an MDS assessment during a selected time window you pick. And that's going to be looking at, number one, the facility conducted the DRR, and then unless the resident wasn't taking any meds. And two, if potential clinically significant medication issues were addressed, that we did the proper contact with the physician, and that the facility, when we contacted them, that got done. The recommendations and actions were done, and there were no potential clinical significant medication issues identified. Quincy admissions. In the denominator, it's going to be the number of stays in the selected SNF window for the SNF resident with the SNF PPS discharge assessment, again, during the reporting time period that's selected. So a new MDS edit in determining SNF QRP compliance came up on 10/1, where we adding the edit to assist us to look at that, which is 3897 equals payment reduction warning. So a dash submitted in the QM assessment item may result in a reduction in our payment. And so we want to look at generated by the following questions: GGO 130, 170, J190, etc. We want to make sure that we're reviewing that. Now we're going to go look over at Section O. And in Section O, 0100A chemo, we're looking for hormonal agent used to prevent reoccurrence of slow growth should not be counted here, such as tamoxifen. That's not where they want to have chemo. Invasive mechanical ventilator or respirator, resident unable to support own breathing and breathing controlled by ventilator could occur during weaning attempts. That's noted because there's been a lot of issues with the particular equipment that's used related to BiPAPs and CPAPs, which you can see enables a resident to support his or own spontaneous breathing. So it's very important to make sure that we are classifying that properly. Now, this is also where we look at the pneumococcal vaccine. I know we all know that CMS's campaign related to the CDC on having people getting appropriately vaccinated unless it's clinically contraindicated or against their belief system, et cetera. Certainly people have the right to refuse, but that has to be very accurately coded on the MDS. The expectation is that people that are living in the nursing homes and other facilities with an increased risk of invasive pneumonial disease or the complicated related to that, which they say people that are 65 or older, and frankly, as I get closer and closer to 65 myself, I don't feel older, but I guess I'm getting there. Specific guidance about pneumococcal vaccine, and so this is a live link. Recommendations for timing for adults can be done, and then up to date in item 0 or O0300A, meaning in accordance with the current ACIP, that's the Advisory Committee on Immunization Practices recommendation, and that link, as you saw, were in the resources. We have 3 certified infection preventions that work at RB Health Partners. If you have any questions about that, you can send it over, and I'll send it to one of the CICs. There are some regional issues related to pneumococcal vaccinations and tourism and things like that. So any questions that you can't find, if you want to ask a question, they'll be more than glad to answer you for that. Here is the live link I referred to earlier, though, for the ACIP vaccine recommendations. Very important to follow those. The MDS 3.0 edited changes, as you can see, here are the links to that. That's a live link. The revised data set live link. And then I always like to spend time reviewing the change table. When we audit, I always have the change table out, and I will recognize sometimes, when we're auditing, I'll see where had the change not occurred, or the change in the definition, it would have been properly coded, but because of the change, it was not, and we identify that. Measure specifications for the measures that were adopted fiscal year 2017. We look at that in the final rule that came out, which is not new. That was from July 2016. Here's the link for that. And then the final specifications that came out for QRP SNF, quality measures, and then the standardized resident assessment data element is included in that. So again, I wanted to make sure you know the accuracy of these materials. Were effective September 14th when we made that. I did do a quick scan last night just to see if we didn't miss anything, and I do not believe that we've missed any changes to anything, but we are in a changing environment, and it's very important to make sure that as you look at materials, you know that you are looking at live thoughts on that. Now, I've got just about 6 minutes left. I don't know if there's any questions that we can answer, or more than happy to have questions emailed, and then we can do a question and answer document, and that can return to Jennifer, and then she can post that for you, in fact, and any other members if they would like to do so.
Awesome. Thank you, Robin. At the moment, I don't see any questions, and I didn't receive any via email.
Okie dokie.
If you have any questions, you can type them in the Q&A box now, and we'll gladly answer those. I would like to thank everyone for joining us today. Robin, thank you for sharing your knowledge. That was excellent. We do appreciate you being here. And again, please watch for your emails for instructions on how to obtain your CEU certificates for the webinar today. And I'd like to thank everyone again, and have a great week.
Thank you, Jennifer, and everybody on the phone. Have a great day.
Thanks, Robin. You too.
Bye-bye.